Now I will hand over the session to our honorable speaker, trainer from Taiwan, Dr. James Tang, to introduce our distinguished participant from Taiwan and continue the training session with our remarkable doctors from Ida Hospital. Thank you.
Yes, sir. Thank you very much, Moderator Ji-Soon. My name is James Tang. I am the Director of International Medical Affairs at the Ida Hospital. I will be introducing the Ida team today. Again, thank you all for inviting Ida Hospital and Ida Healthcare Group to participate in this webinar. So I just want to give you a very brief introduction. Ida Hospital is a Joint Commission International Accredited International Academic Medical Center. We have over 1,800 beds with over 500 physicians in our Ida Healthcare Group. Now, and we also have two medical schools. One is completely in English and one is completely in Mandarin Chinese. Now, as you may know, Taiwan is a small country, and geographically we are located very close to China. And China is being the center of the outbreak. And as of June 4th today, Taiwan has only 443 COVID-19 confirmed cases and 7 deaths. Now, this number represents the total number ever since the beginning of the outbreak. So relatively, comparatively to other countries, Taiwan has done quite well. Now, COVID-19 is a persistent threat to our global health system, and we should all remain on high alert. We understand that Bangladesh also recently faced a natural disaster in Cyclone Amphan. But these events prove that not only do we have to deal with potential health crises, but we also need to be adapt to looming climate disasters as well. Now, we are here to help each other survive this crisis and all the crises that will come in the future. Today, we will share our Ida Hospital's experiences with you, and we look forward to future collaborations as well. Now, please allow me to introduce my colleagues. We are headed by our Executive Vice Superintendent, Dr. Zheng Shenfeng, our Dean of International Affairs, Dr. Liang Zhenlong, our Director of the Infectious Disease Control Department, Dr. Huang Chun-Kai, and then we have our attending physician at Pulmonology Department, Dr. Chen Zhongyue. And we also have our project manager, Ms. Tara Chen. And we also have senior specialist, Ms. Helen Chen, and also our officers, Ms. Wen Zhenxu and Ms. Yu Ding Lin. And we also welcome the charter president, David Chang of the Taiwan Medical Industry South and Westbound Alliance Association, and also the consultant CEO of Flora Xu of the Asia Innovation Development and Entrepreneurship Association Development. Now, to start off, we have two introductions. The first one will be by Director Huang from the Infectious Disease Department, which will share with us on how to manage a COVID-19 patient from a medical perspective. Now I hand over the floor to Director Huang.
So I am Dr. Huang from the Infection Control Department of Ida Hospital. So today I will give a brief talk about how to manage your COVID-19 patient. So as we know, COVID-19 is induced by the novel coronavirus. So basically it's induced the respiratory symptoms. So the symptom, we have a fever, cough, shoulder breath, and chest pain. However, COVID-19 will have another extrapulmonary symptom, headache, diarrhea, and very special, some patient will loss of taste or smell. However, so COVID-19 can induce these symptoms. However, many other pathogens will induce the very, very similar symptom. So the way we know the patient with the COVID-19 is to test and treat it. So, and my first part about how to test the patient with the COVID-19. So actually, you should test all the patient with the symptom or even asymptomatic. However, sometimes it maybe depends on your facility and capacity. So sometimes you cannot test all the patient. So sometimes we should focus on the risk group. So it's my recommendation, example. So sometimes you should check for the history about the TOCC. So maybe from the traveling from the endemic area, or maybe the patient has a risk, the occupation. So maybe, you know, in the hospital, we are healthcare worker, we are relatively high risk. However, sometimes, you know, for the driver, they take the passenger from the airport, they also as a high risk. So we will also test the patient with the cross contact with the confirmed cases, or even there is some respiratory symptoms cluster. So this is the possible COVID-19 patients we should test it. However, sometimes we will recommend we should test for the healthcare workers or long-term care facility residents, because once there is an outbreak, so in the so-called hospital or long-term care facility, sometimes there will be deserts. Sometimes for the pneumonia, so maybe you can test all the pneumonia. Also, sometimes you can set the guideline for the severe pneumonia or even admitted to the intensive care unit. So this is just an example. Sometimes you can follow your country's guideline who should be tested maybe by your capacity. So, and the next problem will be what kind of test you will do. So the first will be real-time PCR. However, sometimes we should know the advantage and the disadvantage, because for the real-time polymerase chain reaction, we just to detection the RNA virus, so to detect the genome. So we just from the nasopharynx or oropharynx or from the sputum. However, we just find the virus may be present in your body. However, we don't know it's alive or maybe it's a dead virus. So from our experience, maybe in the beginning, so maybe sometimes the virus is still alive. However, after 3 weeks, sometimes we test and it's positive. However, it's never be cultured from the culture medium. So sometimes another disadvantage is, so you should take the virus maybe in the exactly period. It means that when you got the infection, it's still in the latent period. So sometimes the PCR will be false negative. The second, you will use the rapid kit. So sometimes I know it's many cases from many countries. So sometimes it was not qualified. So you should know the rapid kits to test for the coronavirus antigen. So you should watch for the sensitivity and the specificity. So and another method, you can test for the patient with the antibody detection. So including the acute phase, the antibody, the IgM, or the chronic infection for the IgG. However, sometimes the antibody only develop after 1 or 2 weeks after infection. So sometimes you cannot use the antibody detection to detect for the newly infected patient. So maybe sometimes you can use 1 or 2 methods combined. It's the same. It depends on your capacity, and maybe sometimes it's a cost. Maybe it's a cost a lot of money to do a test. So when you do the test, when we have a confirmed cases, so in Taiwan, all the patient was isolated in a single room. So however, in the hospital, we have a high standard, so we put it in the negative pressure isolation room. So, and also the patient could be discharged only after 3 specimen negative. So otherwise they will be isolated in our hospital. For the cross contact of the patient, for the cross contact, maybe for the family or the cross friends, they should be quarantined for 14 days. And at that time, they cannot be allowed to go out, so they should stay at home. So, and if the patient developed for the symptomatic, maybe sometimes they has some respiratory symptoms, maybe cough, fever, or something else. So they can send to the hospital for the test for SARS-CoV-2. So once we find the cases, so we are called the confirmed cases, we will send the patient isolated within the hospital. And also the second question will be, we will treat it. However, so it's a new coronavirus. Sometimes it's a no definite antiviral treatment. So you can say that this disease spectrum of the coronavirus is very, very broad spectrum. So 85% is only mild symptom or even symptomatic. So only 15% has a severe symptoms. That means you require hospitalization or need oxygen therapy. And only 5%, so you require the intensive care. So this is why maybe sometimes in the country in Europe, we are not allowed the elderly to go out to protect the elderly patient got infection. However, when we detect it is very, very lucky in Taiwan because most of our patients maybe in the younger group because they will go abroad, maybe in the university, so they come back and they got infection. So basically, you just give the patient for the supportive treatment. So maybe you don't need a specific treatment. So sometimes you should give the supplemental oxygen therapy because the patient has, once the patient has the symptom. So this is example is a so-called is a red flag sign. That means that your absence of breathing or the patient has a severe respiratory distress, central cyanosis, shock, coma, or even convulsion. So that means is a poor sign. So you should give the supplemental oxygen. However, in the patient, so maybe in the beginning, maybe sometimes the coronavirus, the SARS-CoV-2 was not confirmed. So sometimes the patient have pneumonia, you are testing and waiting for the final reports. So sometimes we will treat for the possible bacterial or the viral infection. So sometimes we will give the empirical antibiotics and associate with antiviral, especially, I say that many other pathogens will induce the similar symptoms. So sometimes during the flu season, we will give the antiviral so to kill the influenza virus. Of course, we will give the antibiotics to cover the common pathogen for the community-acquired pneumonia. However, the supportive care do not routinely use the systemic corticosteroid. So sometimes some patient or even some doctor will say, oh, it's the inflammation in the lung. So we give the systemic corticosteroid. However, sometimes it will impair the immune system. So this is why maybe sometimes we give the antibiotics. So we give the systemic corticosteroid very cautiously because when possible, the patient is a relative general specialist, we give the low dose the corticosteroid. Now, of course, there is no different in the treatment, so we give the cross monitor for sign of deterioration. So maybe the patient is a rapid progressive, the respiratory failure and sepsis. From the past experience, the natural course of the coronavirus. So maybe during the first week of the infection, the patient will be stable. However, for the 5% to 15% for the severe case, they will got deterioration after 1 week. So a very, very exact example is the first case in US. So the patient stay in the hospital for the first week and they are stable. However, maybe after 1 week, the patient has a significant deterioration and they got a respiratory distress and eventually failure, needed intubation. So a very interesting the treatment is about the antiviral because it's a new virus. So sometimes some investigation drug was used to treat the new coronavirus. So I will introduce the three, maybe many that will be interested about the antiviral. The first is lopinavir combined with ritonavir. Is we call it Caritra, is one of the protease inhibitor in the treatment of HIV. So however, in the beginning, the doctors in mainland China, they claim so the Caritra can cure or maybe kill the virus or coronavirus. However, recently a randomized control trial is revealed no difference in time to clinical improvement or 28-day mortality among the COVID-19 cases receiving the Caritra and the standard care. However, in up to 13.8% of the patient we have some side effect. So maybe in Italy we don't use the Caritra to treat the patient with the COVID-19. Another very interesting is use the hydroxychloroquine with erythromycin. Sometimes we use the zinc as the 3 compound. So this regimen is very famous because President Trump, so they use the hydroxychloroquine to prevention. However, this study is from France. So they give it a small-scale randomized trial, have suggested accelerated clearance in SARS-CoV-2, received hydroxychloroquine in the early stage. However, maybe another study, they show is no significant difference between the study group and the control group. However, it's the same. Maybe sometimes the adverse event, especially arrhythmia, is a major concern about the hydroxychloroquine. So I will give it another drug. It's the last hope. It's a remdesivir, so in severe case. So recently, I know it's a 3-part article, is 2 in New England Journal of Medicine and 1 in Lancet. So they talk about the results of the treatment of remdesivir. So, and it's promising to improve the outcome. However, the result is a little bit, it's less elective in Asia. So however, maybe sometimes, most of the patients come from mainland China and they claim that remdesivir is not effective in mainland China people. So this is the cases is, the first case is the case report demonstrate the improvement in clinical condition 1 day after receiving intravenous remdesivir on day 7 of hospitalization. And eventually, after use remdesivir, the patient had a significant improvement and eventually extubation and got improvement and discharge. So this is the first cases in US. So my brief introduction is very, very important because you should know which patient you should test and treat. So last time we say Taiwan can help. Taiwan is helping. Thank you.